Well, welcome everyone to Digital Image Contrast, Histograms, and High KVP. I want to warn you that a few of my slides are somewhat lengthy lists of information, and we'll just touch on those. So I'd encourage you to have your cell phone ready if you want to take a few screenshots of those particular slides, and we can come back to them at the end of the presentation during the Q&A session if you need to. So a good place to start on this subject is to make a few notes about how we define contrast. And here are two ways we commonly hear contrast described: how white and black the image appears, or the second one here, the visible difference between two adjacent areas of brightness or density within the anatomy in the displayed image. And I'm not suggesting that we not use that first one ever under any circumstances, but there are some hazards associated with that first definition that I'm going to hope to impress on you in the next few slides. First, let's assume that you have a stomach that is overfilled with straight barium. So you could describe that image as having a lot of whites in it, for example. What you're describing is not really the development of high contrast in the image itself, but the anatomy in it. Similarly, on the right here, an extremity image with large background areas has a lot of blacks in it, but this does not make it the diagnostically useful part of the image high contrast information. So when you set up an experiment on image contrast, you need to be sure to measure the contrast between two tissue areas within the anatomy. Can't overstress that. When you use the background density for one of your measurements, you're really only measuring how bright or dark some part of the image is against a pitch black background that never changes with your technique, and so it is a false indication of contrast. So never include the background density or raw exposure area in your experimental measurements. In fact, this is precisely why the tail of the histogram, as you know, is eliminated for histogram analysis, because it's improper to use that raw background exposure data. Now here's a kind of a hypothetical histogram, and I love using this white to black background on these histograms. I think it really helps your students to understand what you're talking about. So pay attention to that as we go along. This shape is, I tried to draw a shape of a histogram that might have lots of, quote, whites and blacks in it. So we have perhaps on the left here, a spike in the histogram where you might have a large bolus of barium, or on the right, you might have a spike where there's a lot of background, for example, or dark lung area. This does not correspond, this histogram does not correspond to any increased difference between gray levels, which was the second definition we just used, and the more accurate and the more specific and scientific definition that we used to define contrast. So we can see already that there's some tricks, there's some hazards with describing contrast using a histogram. One of the things that the advent of digital has a new concept that has brought to us is the concept of local contrast. And you can see here on this Shimadzu machine on the console on the right there, a setting for local contrast and local contrast limiter. So these are practical applications. There, in fact, are two types of contrast, what we might call global or gross contrast, which is the contrast we're usually describing between larger structures. It's readily apparent at normal viewing distances, and we might describe that kind of as how black and white the overall image appears. But local or detail contrast is the contrast specifically between fine details and edges, and it's only apparent on close inspection or on magnification. And just to illustrate this point so well, if you look at these two radiographs of a hip, on the right side, if I was to ask you which one of these is high contrast, you might, on first blush, say the one on the right side has higher contrast. We could say that that one does have higher global contrast, but look at that image on the left again for a moment. That image on the left has higher contrast between, for example, the cancellous bone and the marrow within the bone structures. So it has higher contrast in fine details. And it's one of those amazing things that digital has made available to us, that we can actually enhance the contrast of small details, select those out. That's part of detail processing's magic, that we can select small details and increase their contrast without necessarily increasing the overall brightness of the image. You see that one on the left, you would not describe that as overall brighter than the one on the right. Kind of neat. So one of the things I want to do is review histograms a little bit, because recently on the ASRT's communities, a question arose as a follow-up to a seminar that had been presented, in which it was asserted that increasing contrast makes the image histogram narrower, that there's this relationship between contrast and the image histogram. The narrower the histogram, the brighter the contrast. Well, if we go back and review histograms for a second, remember that a histogram is simply a matter of counting the number of pixels holding each particular gray level. It is in fact a bar graph, the histogram. It originates as a bar graph that indicates the number of pixels counted for each pixel value. And then, of course, what we do is draw what they call a best fit line on the right here, which is connecting the high points of all of those bars. But remember that this is ultimately a bar graph. Usually the histogram is displayed, or we think of it in our own field, as going from white to black, from left to right. But be careful, that scale can be reversed, and in fact, in photography frequently is. The first machine that I had in my lab, digital equipment that we got in our lab, came up with these histograms that always had a spike for an extremity. The spike was on the left end, and they were also very long and kind of tortuous. And it took me a few moments to realize that those histograms were backwards. They were simply being presented as black to white, and they were being stretched out. So it was took some getting used to. But if you be careful, the histogram interpretation is still the same. You just have to watch that it can be reversed in its presentation. So although the overall darkness or brightness of an image can be represented by the general left to right position of the histogram curve, we know that a darker image will present a histogram that's farther to the right. Nonetheless, this is a histogram is a processing tool. I want to emphasize this. The histogram is not designed to indicate contrast or even anything to particularly do with the visual appearance characteristics of that image. It's a processing tool. It's a mathematical tool. Shortening of the grayscale from higher contrast is a film imaging concept that does not translate to the shape or position of a digital histogram. On the left here, we see some representations of the old step wedges that you used to use with the old film screen technology. And you can see, of course, the step wedge image. What it really plots is the range of densities or pixel values available in the image, but it's not making a count of pixels. It's not a histogram. It has nothing to do with pixel counts. The histogram on the right plots a simple count of pixel values against pixel levels in the image. The histogram is not a step wedge. Now, just as a sidebar, it's kind of interesting to note that a step wedge can be used as an amazing example of digitizing, which is what the ADC does, the analog to digital converter. Not what the histogram does, mind you, but what the ADC does. Because what it kind of does is forces analog values, if you think about it, to be rounded to the nearest available gray level in that step wedge, or the next available gray level in the dynamic range on a computer. And so the severity of that rounding determines the contrast for the initially displayed image. You can see on the right here, the way we shortened that grayscale, so to speak, was to use a penetrometer, if you look at the diagram below, with larger steps, right? So there's greater differences between those steps, and that represents severe rounding of the numbers. So if we were describing this mathematically, we would say that the right image has simply undergone more severe rounding. Well, more severe rounding for set B here on the right in a histogram would actually result in fewer vertical bars, just like on the step wedge, it resulted in fewer steps. which would represent fewer pixel values present in the image. And this would be indicative of shortened grayscale, of course. But here's the key thing. You look at the shape of these two histograms, and you see that if we draw that best fit line, we see that the greater difference from one density to the next is represented by the thicker bars on the right, but the best fit line is not changed. There's no change in the general shape of that histogram due to using higher contrast. And remember how we defined higher contrast more specifically as the specific difference between one density level and the next. And that's not directly related to how the shape of the histogram results. So a greater difference from one density to the next makes the step wedge image narrower, but it does not make a histogram narrower. In fact, image contrast is better represented by using the gradation, processing, or LUT curve that you're familiar with, rather than the histogram. So one thing I want to caution us about is that I fear that we are coming to a point where we spend too much time in class talking about histograms and not enough time talking about practical applications. So we'll come back to that. Just to illustrate this point about histograms not being related in their breadth, or their width rather, to contrast, look at these two chest images, and you see the chest on the right is higher contrast. Then look at the histograms in the upper right corner. And it'd be kind of hard pressed to say that that histogram is narrower, at least dramatically. Look at these knees. And what I did, I have to tell you, it's actually hard to find on some X-ray machines. You can't even bring up the histograms as you're looking at an image, but you're able to do it in Photoshop, interestingly enough. So if you get an image on Photoshop, you can bring up these histograms and you can discuss them with your students that way. But look at these knees and pick out whichever one you think is the highest contrast, and then compare the length or the width of the histogram to the others. They basically are all about the same width. So once again, empirical proof here, experimental proof that histograms are not narrower because an image has higher contrast. Now here's an interesting twist. We took a fogged image on the right and put it in Photoshop and brought up its histogram. And it's kind of interesting. You do notice here that it can, I'm not saying that contrast and grayscale don't affect the histogram shape at all. What I'm saying is it doesn't necessarily make it narrower to have higher contrast. So what we're seeing here on the right, you could say is a narrowed histogram compared to the knee on the left. And that makes sense. If you think about the hypothetical histogram we started with, remember, where we had the spike in the whites on the left and then a spike in blacks on the right. And if you have a very gray image, of course, those are going to be absent and you're going to have a spike in the middle, so to speak. And so that's what we're seeing here on the right, is a kind of a spike in the middle where the mid-grays are represented. But here's the key thing. That is exactly backwards to the concept that high contrast narrows the histogram. In fact, this seems to be indicating that more grays and fewer whites and blacks is what narrows the histogram. Well, sure enough, if we go back to our diagram and consider what would happen if I take this red histogram and I narrow it to the yellow histogram. What do you see here? What happens is we've lost the blacks on the right, or dark grays, and we've lost whites on the left. And what we have left is a bunch of mid-level grays. So narrowing the histogram actually represents a loss of whites and blacks in the image. And this process can be desirable to help show better details in some cases. And it actually has a name, dynamic range compression. This is another one of those practical applications that I think we should be sure to spend time on in class and in our labs. There are several of these things that we can do in our labs now. They're quite different from film screen, but there are things that we can experiment with in our labs that are digital, completely digital in nature, and that are fun to do with your students. So here's this Shimatsu menu again, showing that we've gone to the dynamic range menu. And so dynamic range compression is a common feature in digital processing, but also one that many manufacturers make available on the console here for you to play with. And you see down at the bottom right is the dynamic range compression setting. And you can sit there. I had fun doing this with Christy Carter at her lab in Dallas. And you can see if we set that dynamic range compression at 50, which is the average in the middle for this APT spine, then if we reduce that DRC setting on the left down to 31, you can see that that's kind of a brighter image, particularly down in T12, L1 area. You start actually losing details because of excess contrast. And so if we then crank that dynamic range compression up to 96, we're compressing the dynamic range here. And remember, compressing the dynamic range means more grays, in fact. And so what you see here is a kind of a grayer image overall, but indeed it has more details visible. So that's an example of how an image can be improved by using the dynamic range compression feature. Now, this can get a little confusing, so let me spend a few minutes, and I hope these illustrations are helpful to you. Dynamic range compression, we might better think of it as truncation, in other words, a cutting off or a clipping off of the extreme ends of the grayscale. So this S curve you see at the top of the diagram, what we're going to do is clip off the blacks and the whites. The result in the chest you see below is going to be on the right, that you have a grayer looking image, which actually isn't that pretty, but frequently can have better visualization of details. And so here's the weird part, is that that elimination of the darkest and the lightest densities in the grayscale range actually results in a grayer looking image, whereas it seems to contradict our conventional teaching with film screen that the shortening of grayscale represents increased contrast. Now, both of these concepts are true, but you have to understand what we're doing here, and that they belong to two different domains of imaging, film screen versus digital. So on the left is our old-fashioned step wedge image. We know that conventionally, if we shorten the grayscale, the trick is to remember that that image, if you look at the step wedge images at the top, still begins with blank white, and it still ends with a pitch black. And so what we've kind of done, you can think of it as squeezing the range of densities. So from film imaging, when we squeeze the range of densities such that the extremes are still there, then we get shortened grayscale. Now with dynamic range, which is on the right here, we are rather clipping the whites and blacks out of the dynamic range. We're taking those out of what's available to construct that image on the monitor that we're looking at. And ironically, what we see here is what appears to be a grayer image. So in a sense, you've shortened the grayscale, and yet you've made it grayer. So it can be a little confusing. Lengthening the grayscale by increasing kVp makes the image look grayer because there are more shades of gray present in the remnant image reaching the detector, whereas DRC makes the image look grayer because the lightest and darkest shades are now missing from the dynamic range. So this brings us to kind of a general point that I want to be sure and emphasize, that film processing involved the development of densities which were chemically tarnished silver, and that things have changed radically. What we deal with now is sets of numbers and numerical data. It's a completely different world, and many of us are still trying to catch up with this. But it opens some possibilities for reducing patient dose, and that's why it's so important that we understand these digital concepts. And so in the November-December 2020 issue of Radiologic Technology, Dr. Beth Villay from Midwestern State University and myself, we published this article, Standardizing Digital Radiography Terminology, which I encourage you to look up, and we'll list this again on a later slide. But I just want to summarize for you the 5 main points that we made, which come down to, in effect, a failure to adapt to digital technology and a tendency that we have to cling to film screen concepts that are just no longer appropriate. And so here are 5 causes of the confusion that we identified. First, mixing projected image and displayed image characteristics, the projected image versus the displayed image that has been computer processed. Second, mixing digital terms with film screen technology, and particularly continuing to emphasize the detector. The detector is not the main change that has occurred with digital. The computer is. Number 3, mixing equipment terms with image characteristics. Number 4, mixing physics terms with clinical radiography terms. And number 5, restricting image qualities to only 4. So if you want to see the details of this discussion, I encourage you to look up that article if you haven't already seen that and read through that. Now, a really critical point that we make is that we need from the beginning, as we look at digital terms, to clarify which stage of image production that we're discussing. So the projected image, some of us are calling this the signal image. So understand that if you see that word signal, we're talking about the projected image. We have a group of educators, a group of authors that got together, and we actually went through, we had signal image at one point, but we decided that projected image was the clearest term for this. And we defined it as the image information carried by the remnant beam prior to any capture by the image receptor. Then we define a latent image as that image that is stored by the detector. But in digital, this process only lasts for a few seconds. The displayed image is the processed image used for diagnosis. For digital images, the initial displayed image can then be further modified through windowing and leveling and other operator controls. Really important distinction to make between the projected image qualities and the displayed image qualities. So here's a list, and you might want to take a screenshot of this because I'm going to move on. So if you want to get this down, get a screenshot of this. A list of related articles to this whole discussion on terminology. And I want to particularly call your attention to this top one, the July-August 2021 issue, and go to page 634, which is a response to this discussion by Dr. Beth Villay, myself, Euclid Serum, Charles E. Willis, who is a medical physicist, Christy Carter, and Dorothy Saya. I hope you'll look those up and read them if you haven't. In our original article by myself and Dr. Villay, we just find subject contrast as the difference in radiation intensity between different portions of the remnant X-ray beam. And subject contrast is determined by the absorption characteristics of different tissues within the body in relation to the X-ray beam energy. And what we're trying to do is distinguish between this and final image contrast, the displayed image contrast. So you see in this table that we've placed here that, let's see if I can find my pen. There it is. Okay, sorry about that. So you can see up here under signal image, which should say projected image, okay? Under the projected image, we have the quality called subject contrast. But over here under the final displayed digital image, we're now just simply calling that contrast or grayscale. And that's the distinction that's so critical to this particular presentation. Let me just point out while we're at it, look at the very top listing there. The projected image on the left has the quality of receptor exposure, which is controlled by mass. But on the right, when we get to that final displayed image, the quality is now going to be called brightness, which is controlled no longer by mass, but by rescaling followed by leveling. And we're going to illustrate those concepts here in just a second. So remember that film-based analog radiography required a subject contrast difference between tissues of at least 10% to resolve details. This particular graph is in several of the radiologists' physics textbooks. Because of its contrast enhancement capabilities, digital imaging can resolve tissues with only 1% subject contrast. So digital has 10 times the exposure latitude of film technology. Another way of stating this is digital units are 10 times more sensitive to the incoming subject contrast, and that's why CT can distinguish between gray matter and white matter in the brain, whereas conventional radiographs can't. So I want to pay particular attention to this slide. This is the raw image from the detector. Remember, I mentioned that some of us, one of the problems we're having is that people are continuing to emphasize the role of the detector when it actually should be diminished somewhat, especially compared to the computer. Here's one good reason why. This image was provided by Fujimed years ago as a representation of the image that comes from the detector, mind you. This isn't what's going into the detector. It's what's coming from the detector into the computer. So this is the detector image. And it is simply not true that the old optimum kVps are still required in order to supply the computer with, quote, sufficient contrast. If that were true, this image would never be able to be produced or converted into a good diagnostic image. And that's what computer processing does every day. So this is what the raw image looks like. So what I want to do is start with some things I know we can agree on that should, I hope so, that should be apparent just as we visually look at these things and are obvious. First, the brightness or darkness of the initially displayed image on the monitor now we're talking about, that brightness is determined primarily by digital rescaling. Now I'm distinguishing this from kVp. We're going to come back to kVp. That is primarily determined by rescaling. And then we control it at the display, right, by adjusting the window level. Should be obvious. The contrast, likewise, of the initial displayed image is primarily determined by LUTs, lookup tables, that are used during digital gradation processing, and then we can play with it by adjusting the window width. So just to drive this point home, a couple of illustrations because we're going to make a comparison here. So you can see that leveling on the left here using a CT image controls the brightness, and it's very dramatic. And that on the right, we see that windowing or window width controls the global contrast. And we see a very dramatic change there as well. So we can make tremendous dramatic changes in the appearance of the image contrast by windowing and leveling, okay? Now, another way to do that, to make dramatic changes, as you know, is to process that image under a different algorithm. So we have a chest here in the middle that was used, that chest algorithm was used to process, and some of us do this experiment with our students. On the left, on image A, we have that same chest, the same technique, same KV, same mass, but we processed it as a foot. And on the far right, we see the same image again with the same technique and processed as an abdomen. What we're doing here by using different processing algorithms is we're changing the rescaling that's being applied by the computer. That's a preset for each anatomical area. And we're changing the gradation LUTs that control the global contrast. So this is to illustrate the degree, the dramatic difference that rescaling and gradation make. So now we've covered two digital types of factors that really dramatically change contrast. First of all, the rescaling and the LUTs that present the initial image, and then secondly, the window leveling and the window width adjustments that we make after that image is displayed. So these are tremendous differences, and it's very obvious. Now, in comparison to this, look at these two images on the lower right, which represent or digital images of a phantom abdomen with a 24 kVp increase. That's roughly a 30% increase in kVp. Is the right image dramatically reduced in contrast? Bear in mind these images we just demonstrated. And come back and answer again, is it reduced visibly? Yes, there's slight reduction in contrast. We can all see that. But would you call that a dramatic loss of contrast when we consider it in the context of the last few slides that I've been showing you? The truth is that kVp with digital equipment in this digital age needs to be considered as a contributing factor to the final contrast, just as we consider the size of the body part, the filtration, the field size, the grids, the OID are all contributing factors. And what we need to do is to be up to speed is to list kVp with these other factors. We're not saying by any means that kVp does not affect contrast in the final image. What we are saying is that the term control is far too strong a term to be using when we're discussing the relationship in the digital age between kVp and the final contrast in the image displayed on that monitor. Digital processing effectively allows us to choose our step weights, thus wresting control from the exposure setting. In other words, it removes the control very much so from the exposure setting and places it in the computer. Image brightness and contrast are controlled not by the exposure to the detector, but by post-processing. Now that's a direct quote from the American Association of Physicists in Medicine, the AAPM, from their 2009 paper on exposure indicators, which we will cite later on here, so I'll give you that reference if you haven't read that. But that's a direct quote from the physicists. Brightness and contrast are controlled by post-processing, not by exposure to the detector. This is one of those slides you might want to take a screenshot of. I'm not going to read through this, and you'll be glad I don't. But what I did is I made a list of the types of errors that we frequently make in setting up experiments and in interpreting the results, especially with digital equipment. Some of these listings we've already discussed, and others we're going to talk about as we go along here. And I'll have this at the end of the presentation if you want to get another chance to take a screenshot of that. One of those errors is basing our conclusions on insufficient data. And in the digital age, here's what you have to do. It turns out that digital manufacturers each have their own algorithms that are patented. And in order to get their patents, they each have to have a slightly different process. Some digital manufacturers aren't as good as others at processing these images. We all know that. And so what you cannot do is give a presentation and use these images on the left, a single example from a single, maybe you have only one brand of equipment in your lab. You can't take a single brand of digital equipment and draw a bunch of conclusions that we're going to generalize to the whole world when you have 13 different manufacturers with 13 different patented algorithms for processing. So what you need to do, I believe, is something more like the 2011 study that I did with Dr. Phil Hines from the University of New Mexico, and a physicist, and Dennis Bowman, where we studied over 200 images in order to establish the changes that have been caused by digital imaging to two key questions: whether increasing kVp will fog the image, and whether increasing kVp and reducing mass will result in model. And we went into great detail. We had other educators send in samples from their particular brands of equipment. We traveled to get these different brands. We studied 11, we collected data on 11 of the 13 manufacturers. This is the kind of thing you need to do to establish a concept, to generalize concepts that we're going to teach when we're dealing with digital. Another common mistake in experimenting with contrast is to base your conclusions on extremes in exposure. Now, if you look at this image down at the bottom, these two bar images, we have a density on the left of a 0.5 and a density below that of 1.0. By the way, those are flipped upside down, right? I got those upside down. So flip those numbers vertically if you would. But the ratio between those numbers is 1.0 divided by 0.5 for a contrast of 2.0. Now, if we double that density overall on that image on the right here, then the density of 1 will be doubled to 2, and 0.5 will be doubled to 1. We make a ratio out of those, and we get a contrast of 2.0 once again. So this is a doubling the mass is something that we might do realistically in a clinical setting. But there's a wide range of exposures within which the image can be darkened or lightened without contrast being affected. And this proves that point. And there are other publications and talks that I've done that discuss that more fully. So related to that concept of using extremes in exposure is also using clinically unrealistic conditions in order to establish general rules. So if you hear someone do a presentation and they use an elbow, and they go up 50 kVp from 50 all the way up to 100 kVp in order to make a point, there's two problems wrong with that. First of all, going up 50 kVp is an extreme, as we've just discussed, and also it's not a realistic kind of a change that we might make in clinical practice. In addition to all of that, using an elbow does not produce measurable scatter in the first place. If you want to demonstrate the effects of scatter, we should be using an abdomen. Don't use a chest, Don't use an extremity. You should be using an abdomen so that you generate plenty of scatter to begin with. That's what we've done here. And you see on the right-hand side, we've got a digital image of an abdomen phantom at 122 kVp. And I would submit to you that in the film screen days, that image would be pitch black. On the left, we have an old-fashioned film image with only 86 kV, but the patient is hypersthenic. And we all know that a hypersthenic patient produces a lot of scatter radiation. So once again, slight reductions in contrast that we see in digital images, maybe they're not necessarily due to scatter, which they seem to always be attributed to. Maybe they're attributed to, maybe there was because of initial penetration has increased. Maybe it's because of the later digital processing settings. Maybe it's even because of the settings on the control monitor that you're observing that image on. There's several things that enter here, and all of those things affect the final image contrast. So we have to be careful about what we attribute to scatter. In fact, traditionally, even before digital, I realized, even as a student, I could see at some point that high kVp kept being blamed for destroying contrast as if it were the primary culprit. Well, if this were true, why have we always been able to use 120 kVp on a chest? It's because the aerated lungs in that chest do not produce much scatter radiation in the first place, just like the elbow, even at 120 kVp. That's why. So it has to do with the anatomy. The main cause of scatter is not and never has been high kVp. I'm not saying high kVp doesn't contribute. I'm just saying that it's not the main concern. The main cause of scatter is, in fact, large volumes of exposed soft tissue. That's why you need to use an abdomen in your contrast experiments. So large soft tissue body part thicknesses and large exposure fields result in large volumes of exposed soft tissue, which produce a lot of scatter. But digital technology is way more resilient at cleaning up scatter than, of course, films were. Here's a row of abdomen images at the top with increasing kVp, and a row of digital images at the bottom with the same exposure factors. Let's skip that one. Now there's a camp that has arisen, a school that is hanging on to the notion that kVp controls contrast and that we cannot go up in kVp even a single 15% step without taking risk of either fogging the image or producing model. I call them the garbage in, garbage out camp. I first heard that concept in an online seminar 20 years ago when the speaker said, computers can't deal with this. If you put garbage in the computer, you're going to get garbage out. Now, computers are not chemical processors, which simply develop an image whose properties have already been irrevocably determined by the exposure factors we used upon exposure. This statement, you can't make chicken soup with chicken poop, it may be catchy, but it might be true if nothing but bad information was being entered into the computer. But this is not what we're dealing with. Rather, what we're dealing with in an X-ray beam is good information that has had some bad information in the form of scatter added to it. In this case, if we can simply remove that noise, then we will have a good image remaining. The computer is perfectly capable of removing most forms of noise from the incoming signal, and that includes most scatter. So a question came up at a recent seminar of why soft tissue, there was an image that was demonstrated at high kVp, and one of the attendants asked at the end why soft tissue was showing up better. And that sounds weird, doesn't it? Because in film days, if we had higher kVp, we wouldn't expect soft tissue to show up better. Well, the answer again is digital processing. It's because digital processing is the key thing that is controlling this rather than the initial exposure factors. If it was true that you can't make chicken soup with chicken poop, and that was literally true for all occasions and all instances, then how come grids can improve an image by eliminating scatter radiation from the signal before it reaches the image receptor? In digital processing, the equivalent of that is eliminating noise from the numerical data before the image is displayed. Not only can computers do that, they can extrapolate information and insert it into the digital image. And this is why you hear about intelligence agencies, and you see these movies about this, where they take satellite images and they say enhance, right? And they do something in the computer, and all of a sudden you can tell some detail, you can make out some detail that wasn't recognizable before. That's real stuff. Computers really can do that. And that's why intelligence agencies can enhance satellite images in order to make them more clear. Now, our teaching needs to be based on science and not on slogans. So here's the first paragraph of the report of the physicist group, task group number 116, that was published in 2009. This information is now almost a decade and a half old. And I want to read just a couple of parts of this to you verbatim. So unlike screen film imaging, according to the physicist, image display in digital radiography is independent of image acquisition. The final brightness and contrast are modified by digital processing. And then you drop down a ways and it says the brightness of the image is controlled not by the exposure to the detector, but by post-processing applied to the image data. This may be a new and confusing concept for operators of digital radiography systems who are accustomed to screen film imaging. So the brightness and the contrast are controlled not by the exposure to the detector, but by the post-processing. And that post-processing includes, as we've discussed, first of all, leveling and windowing. Secondly, rescaling for brightness. Third, LUTs for contrast. And fourth, what we haven't discussed is detail processing, which also affects the local contrast of details. These post-processing factors are frequently being forgotten or ignored in our textbooks and in our presentations. So I just want to emphasize that, and these next couple of slides, I'm going to kind of skip through these a little bit, just to make the point that not only can the computer clean up scatter in general, but they also have methods of identifying specific fog patterns and eliminating those. And we don't have time to go into that, but here are 4 images of a lateral L spine using film screening. You can see the fog on all of those except the leftmost one. You see that the spinous processes are burned out. On the leftmost image, I take that back, it's the rightmost image. The rightmost image, you can make out the spinous processes all the way to the back of the process. On all 3 of the others, it's burned out. Here's the same kind of experiment done with digital, and we see just the opposite. We see the back ends of the spinous processes on all of these images except, golly, I can see it on all of them right now. You could argue that maybe the worst one, you can't make out those spinous processes. My assertion is that 3 out of 4 times a digital lumbar spine is able to show those. Now again, I didn't say that it never shows up fog. What I'm saying is that most of the time, computers are able to deal with it. To the contrary of the idea that we have to have a high contrast image going into the computer, we might assert just the opposite, that what we need is sufficient input grayscale. So listen to this rationale. If we start out with a long scale input image, and then if we desire to have it shortened, we want to shorten that grayscale, the computer can select every other density in that step wedge, so to speak. And in this case, all of the final information displayed consists of real values. If we do the opposite, if we start with a short scale image and then we interpolate or extrapolate new values to make it long grayscale, those values are fabricated, so they constitute artificial information. So it's desirable to actually use long grayscale, which again leads us to high kVp. High kVp, as you know, can help us to reduce patient dose, and I want to just emphasize, I've only got about 5 minutes left here, emphasize this concept. The study we did that I mentioned earlier, where we studied over 200 images, here's some of the results, and the conclusion we came to is this, that for digital systems, the overall reduction in image contrast is usually indiscernible for a single 15% step increase. In other words, you pick any 2 of these adjacent and go from one to the next one, and we believe that that was proven for 9 different manufacturers. We also did multiple studies. All of these images and study results are in the textbook Radiography in the Digital Age. We studied the model. We had radiologists evaluate the model on all of these images. This was our conclusion. we can make a single 15% step increase in general on all digital equipment with an accompanying halving of the mass across the board for technique charts, with the possible exception of chess, since they already started 120 kVp. We indeed found that on several manufacturers, you could do this at least twice before model began to appear, thus reducing patient dose. So we are not asserting here that fog never appears on digital radiographs, nor are we asserting that we should use 50 kVp higher than before we use digital. What we're trying to suggest is we can now use at least one 15 per step increase, which will reduce patient dose by 1/3. So the experiment must fit the question being asked. That's another one of those errors that we talked about. A 50 kVp change does not address the question of whether a 10 kVp change can be taken advantage of in order to reduce patient dose. Here are some related presentations on ASRT Live Online that I've done, and Barbara Smith in the last year. And then take a screenshot of this if you'd like. I encourage you to go back and look at these. There's some really important points there that mainly come to this, that digital imaging, because of its wider exposure latitude, allows us much more flexibility in every way than we used to have. So the idea that the computer needs high contrast input, the idea that kVp is important as ever, or that grids are important as ever, in fact, it's just the other way around. And I have a presentation that talks about grids. Here's an example. Let me just show you this real quick. An example using APT spines of filters. And the idea here, you see the film image on the left with the dark cervical thoracic area, and all three digital images on the right, which means that we no longer have to worry about getting that wedge filter out or using that saline bag for the most part. I didn't say never, but we no longer have to worry about that on most patients. And so, again, the filters are less important. Grids are less important. It allows us flexibility to experiment with things that would reduce patient dose. And so I have an ASRT Live recorded presentation, and some of you may not be aware that these ASRT Live presentations are archived, and you can go back and simply look up this topic and go back however many months or years ago and watch these presentations. So I spent an hour on this one discussing grids and how we can reduce grid use. So can we leverage the extraordinary exposure latitude of digital equipment in order to reduce patient dose? I want to emphasize that I believe, and many of us believe, that yes, we can, and that we absolutely should. So I appreciate you coming, attending this presentation. I hope you got some useful information out of it.
So you have a few questions there, Quinn?
Yes.
Okay.
Yeah. So the first one is, doesn't changing kVp affect the shape of the histogram, though it may not affect contrast due to the LUT? And again, I tried to clarify that shape. I'm not saying that the shape isn't changed at all. I'm just saying that the change in the shape is not a narrowing due to increased contrast. That's a false concept. I'm not suggesting that the shape doesn't change at all. Let's see. Can quantum model be corrected by an increase of either mass or kVp? You know, that's an excellent question. What matters in quantum model is the total exposure. And if you read the physicist publications, you will see this, that they constantly talk about not sufficient kVp or sufficient mass, but they talk about sufficient exposure to the detector. So exposure to the detector, all the detector cares about is it's counting how many X-rays hit it, so to speak, and that depends on both sufficient mass and sufficient kVp. And something that's been really confusing is that people tend to say, well, we have to increase mass in order to get more exposure to the detector. But why isn't it true that higher kVp also gets more exposure to the detector because of increased penetration? Either one can be used to increase detector exposure, and either way, you're helping to reduce model. So increasing kVp, we can make an argument that it actually may help prevent model. And a lot depends, as we said, on the patient anatomy. If digital images can be modified post-exposure, are grids no longer necessary? You know, that's interesting. I just would encourage you to go watch my grid presentation that I mentioned. on ASRT Live, and that we spent a whole hour talking about that. And we have virtual grids now as well. And to kind of summarize my recommendations in there, I'm recommending 3 things: using grids, going non-grid on some things that we used to do grid that are borderline, such as shoulders and necks, using lower grid ratios, and also combining virtual grid technology. If you use the virtual grid, you may be able to get by without a grid or with a lower ratio grid. So what the least we can do is reduce, at least we can bring grid ratios down. So there are actually several possibilities there. And I found that we can actually we could cut patient dose in half twice. I'm not kidding. We could bring patient dose down to 1/4 previous levels if we took advantage of all of those things. Don't you still need an optimal kVp for proper penetration, preventing over or under penetration? Absolutely. A minimum kV is necessary. A certain minimum is necessary to penetrate the anatomy. But that's kind of a secondary question to whether higher kVps create too much scatter or not. But yes, there is a minimum. And what we've done in several of our textbooks, myself and a few other authors, is we've taken that 15% increase recommendation, and we've made a new chart of optimum kVps, which are in general are 15% higher than they used to be. So an optimum level is absolutely still required. Let's see. Based on the capabilities of today's digital systems, it's still possible to use a kVp that's too high for a given part to the point where the projected image no longer contains sufficient differential attenuation. I expected that question to come up. It comes down to whether a minimum level of contrast is required going into the computer. And I absolutely agree with that. There is a minimum level of contrast or a minimum level of differentiation that's required in the data that's going into the computer. But that's not, the problem is, if you go back to the slides that I mentioned about the latitude of digital equipment, remember that we said that it has 10 times the exposure latitude. So the amount required now is 1%. The amount required with film was 10%. So that has changed. There is a minimum amount, but the minimum amount has gone down by a factor of 10, which is huge. And what that does is that opens up possibilities for us to, again, to save patient dose. Okay, let's see. What are your thoughts on virtual grid as an actual grid? Virtual grids are not quite as effective as real grids. And so one of the things we did in that presentation is talk about using them in some combination. And is the possibility not for necessarily eliminating grids altogether, but for reducing grid ratio. If we would use the virtual grid technology and use some of the other things that are discussed in that lecture, in that presentation, what we could possibly do, for example, is cut all our grid ratios in half, including all of the grids that are in our bucky trays in their tables. We could be using perhaps 8-to-1 grids or 6-to-1 grids instead of 10 or 12-to-1 grids, and that saves patient dose again. Let's see. Try to see if there's some that I've skipped over. I heard that digital receptors are more sensitive to scatter. If this is true, I want to know why. Thank you. Well, I don't know all the physics behind it. In particular, it would take probably 15 minutes to do that anyway. But it's true that digital receptors are more sensitive to scatter fogging, and that's why we don't, want to set them out in the room and so forth. But there's another important distinction to make between that and how sensitive the whole system is. This is really an important distinction. I call this pre-fogging. If you pre-fog a cassette out in the room before you use it, computers generally cannot compensate for that. And so you see these wonderful demonstrations that we show our students to avoid pre-fogging of detectors. That's a different question from asking whether the computer processing a regular image that has been scattered in exposure, but not, that has some low contrast during the exposure, is able to go in there and adjust for that scatter and compensate for it. So in other words, I'm saying that pre-fogging an image, pre-fogging a cassette is a little different question than asking, because the whole system as a whole, including all of the digital processing, process, is it able to cope with scatter radiation in general? And I still assert that it is, and so much more so than we used to be able to with film and screen imaging. I think I've just about answered all the questions that came in. There's a question here about submitting to PACS, but it's just kind of oblique to what our discussion has been, so forgive me if I don't go into that. Early on, technologists were forbidden to window rescaling images before it goes to the radiologist. I guess that's part of that same question. I think I've covered pretty much everything. Thoughts on virtual grids. So how are we doing on time, Mitchell?
We've got about 2 minutes left. 1 minute.
Well, maybe what we can do. Let me just do this slide real quick, take 30 seconds. The new role for technique, there's a new role overall for technique, and it's not to control contrast and the brightness of the image. It's to provide an adequate signal. We kind of had that discussion about detectors a minute ago. The role for technique now is to provide sufficient signal to the image receptor so that the computer has lots of data to manipulate. And again, you can achieve that with either higher kVp or higher mass. And I hope in this presentation we've given you some ideas for ways that we could do that and ways of applying that concept. So again, appreciate you all attending. Thank you.